Bismillahirrahmanirrahim. Good afternoon, ladies and gentlemen. Welcome to the plenary session 6. I'm Dr. Hina Latif, Associate Professor of Medicine at King Edward Medical University, and I am Secretary Information PSIM. And it's my pleasure to serve you as moderator for this session. We are joined today by an illustrious panel of chairs who bring a wealth of academic and clinical mastery to this session. Please join me in welcoming our chairpersons for this session. Our first chairperson, Professor Mushtaq Haroon, a legendary figure in the field of medicine, who has served in different hospitals in various capacities. With a Lifetime Achievement Award for Professional Excellence, he currently leads the Emergency Department at PKLI and Research Center. May I welcome Professor Mushtaq Haroon on the stage, sir. Our next chairperson for this session, Professor Atar Javed, a highly esteemed neurologist known for his commitment to comprehensive, patient-centered neurological care, teacher of the teachers, and obviously my teacher as well. A warm welcome to Professor Atar Javed on the stage. Our next chairperson for this session, Professor Noman Tarif, a renowned expert in the field of nephrology, whose reputation for managing complex kidney failures is recognized across the region. May I request Professor Noman Tarif to be there on the stage? Our next chairperson, Professor Ehsan Noman, a proficient neurologist who is currently heading Department of Neurology at King Edward Medical University. Also my teacher. May I request Professor Ehsan Noman to be there on the stage? Our last chairperson for this session, Professor Shafat Khatun. She is head of internal medicine at PIMS, Islamabad, and she is chapter head Islamabad, Pakistan Society of Internal Medicine. A big hand of applause for my worthy chairpersons of this session. While a kidney transplant is a life-saving procedure, the medical honeymoon period requires vigilant surveillance. Cardiovascular disease remains the leading cause of death in kidney transplant patients. This makes the role of internist managing blood pressure, glucose, and immunosuppression just as critical as the surgery itself. To guide us through this intersection of care, we are joined from the University of Vermont, USA by Dr. Kanza Kaq, a graduate of Fatma Jinnah Medical College and a former fellow of Johns Hopkins. Dr. Kaq specializes in transplant nephrology and the innovative use of POCUS. Dr. Kaq, the floor is yours. A big hand of applause for Dr. Kanza.
Thank you so much for the introduction. I'm so glad Dr. Hood introduced me to this conference. I'm excited to be here and very happy to see efforts to advance medicine in Pakistan. As you all heard, I'm talking about kidney transplant, issues of concern for the internists. Because first and foremost, we are all internists. As a kidney transplant physician, I do see and manage a lot of internal medicine conditions. And regardless of specialty, we're going to see transplant patients and we're going to see patients with kidney disease. Before we get into this, the first question is, why are we talking about transplant? I can tell kidney transplant is the treatment of choice for eligible patients with end-stage kidney disease. And of course, there's going to be exception to this rule. So transplant is not for everyone, but for suitable patients, it is the optimal treatment. And we can see here, there is compelling data which shows that patients live longer if they get kidney transplant as compared to remaining on dialysis. For example, you can see this here. So you can see this graph over here. We are looking at population projected life years. So tall green bars are representing population life years if a person is a member of general population. Then we can see the blue bars, which represents the remaining life years if a patient is on dialysis. And you can see the red bars. That is the population projected life years if the patient gets the kidney transplant. And you can see there are life years gained if a patient gets a kidney transplant as compared to if they remain on dialysis. Although the life years gained is not enough as compared to the general population. And this is also very elegantly shown in this hallmark study from NEGM. And we are looking at survival in patients who get transplant as compared to the patients who remain on wait list. And you can see, even though there is initially some mortality after the procedure, but later on by day 244, there is clear survival benefit with transplant. And not only patients live longer with kidney transplant, they do have a better quality of life as well. When we talk about care of patients with kidney transplant, It is a unique medical care. These patients already have wide range of pre-existing medical conditions, and on top of that, we are using immunosuppression, which make things more complex. So their medical problems are more prevalent, they're more severe in presentation, and they're more atypical as compared to the general population. When we take care of these patients, we do have two goals. We want patients' kidney allograft to survive, but that is of no use if patient is not with us. So there are things and factors which cause allograft failure, but then there are factors which lead to patient mortality as well, and we have to pay attention to both. And over time, with better immunosuppression, kidney allografts are lasting longer, and kidney transplant recipients are living longer as well. But as a consequence of this, we do have this population with complex medical needs. And we do need help from internal medicine physicians in order to take care of these patients. Because the kidney transplant physicians take care of these patients for the first few months or maybe a year or two, after that, the patients follow with internists and general nephrologists as well. So internists should be aware of their complications, medications, and chronic medical conditions which are unique to this patient population. This slide here just gives an overview of different aspects of care of these patients. We monitor the allograft function, we manage their immunosuppression, but on the other hand, we also look at their comorbid conditions, which they either already have or they develop as a result of immunosuppression. For example, cardiovascular disease, hypertension, dyslipidemia, diabetes, infections, and malignancy. And I'll talk about most of these individually as well. I'm going to start off with immunosuppression, because I believe that is the core of what internists need to know when they take care of these patients. Immunosuppression for kidney transplant consists of two phases. One is induction, which is the high-dose immunosuppression that we give at the time of surgery. And then there is maintenance immunosuppression that is started in the hospital, but patients remain on it for the life of their allograft. So maintenance immunosuppression is more important for the internists. Maintenance immunosuppression consists of different medications across different medication classes. So we do have calcineurin inhibitors or CNIs, and it comes in two flavors, tacrolimus and cyclosporin. Our second immunosuppression is anti-proliferative agent or anti-metabolite agent. We do have mycophenolate mofetil, and when transplant was starting, maybe in 1960s, we used to use azathioprine, but more recently, mycophenolate mofetil is the preferred agent, although we still use azathioprine in certain conditions. And then there is steroids, which patient may not be on due to changing protocols recently. You will also see patients occasionally on some other medications, which are mammalian target of rapamycin inhibitors, so mTORs, sirolimus and everolimus. We don't see it very frequently because of increased risk of patient morbidity. And then there are some newer agents, belatacept, which is an intravenous agent, and you will see it mostly in the patients who did not tolerate calcineurin inhibitors or CNIs in first place. And we talked about all these medications, but every transplant center has a different protocol. So what you can see here is on the top, this dark blue shows that majority of the patients are on the combination of three drugs, which is tacrolimus, mycophenolate, and steroid. And then the second blue line here shows the rest are on either tacrolimus or mycophenolate. So in total, almost 90% of the patients are on these drugs. And calcineurin inhibitors are the backbone of more immunosuppressive regimens. And as I mentioned before, the patients will be on these medications for the life of their allograft. So many of the problems and issues they're going to face are either related to these medications, so we should be aware of the side effects as well. And calcineurin inhibitors, even though they have improved graft outcomes, but they do have a lot of adverse effects. I say calcineurin inhibitors therapy is a double-edged sword. So you can see the side effects are multiple and they range across multiple organ systems. You do have nephrotoxicity, so you can say acute kidney injury. But on the other hand, you can also have chronic nephrotoxicity and it can lead to graft loss. Then there are other complications like hypertension, new onset diabetes after transplant, dyslipidemias, multiple electrolyte abnormalities, alopecia with tacrolimus, and then hirsutism with cyclosporin, and then neurotoxicity. So patients are going to report tremors, insomnia, and sometimes these adverse effects are severe enough that these become intolerable for the patient. And not just that, there are some drug interactions as well. Calcineurin inhibitors and metabolized by cytochrome P450. So medications which interfere with this metabolic pathway can affect calcineurin inhibitor levels. So here are the examples. There are some common drugs which increase calcineurin inhibitor levels because these are inhibitors of cytochrome P450. The common ones that we see are verapamil, diltiazem, azole antifungals, erythromycin, clarithromycin, and protease inhibitors. And if these drugs are used, they will increase calcineurin inhibitor levels, so there will be toxicity for the patient. And there are other drugs which decrease the calcineurin inhibitor level. So there are cytochrome P450 inducers, which are rifampin, phenytoin, carbamazepine, and phenobarbital, and many more as well. These will decrease calcineurin inhibitor levels, so that can result in rejection. So monitoring trough levels is critical component of balancing risk of overexposure and underexposure, because these are the medications with narrow therapeutic index. So if you're stopping or starting any of these medications, we have to be very cautious. I'm going to move on to allograft function. So KDIGO guidelines recommend that all kidney transplant patients be considered as having chronic kidney disease, regardless of their EGFR or presence or absence of markers of kidney damage. And it's important to remember that not everybody is going to end up with a creatinine of 1 and EGFR of 90 after a kidney transplant. Almost 35% patients have EGFR of less than 45 at 1 year post-deceased donor kidney transplant. And almost 50% of those patients will experience graft failure in their lifetime. And the causes of graft loss could be multiple. There can be rejection, recurrent disease, de novo kidney disease, or drug toxicity. And here I am showing you the electron micrograph of glomerulus. You can see AA, which is afferent arteriole, and it's supplying blood to the glomerulus. And you can see when patients are exposed to high doses of calcineurin inhibitors, there is vasoconstriction, and that can lead to rise in creatinine and EGFR. And if we were to biopsy patients who have been on these agents for maybe 10 years or more, you would see evidence of toxicity in almost 100% of the kidney biopsies. So it's really important to monitor trough levels. We do try to reduce the doses and trough level targets if possible, but keeping in mind the risk of rejection. And because many of these conditions are initially asymptomatic, it's also important to monitor kidney function closely for these patients. Kidney transplant recipients are hospitalized 6-fold higher as compared to general population. And one of the reasons for hospitalization is acute kidney injury. Allograft has a higher susceptibility to acute kidney injury because, as I mentioned, use of calcineurin inhibitors. There is the effect of hyperfiltration because this is a solitary kidney now, and the lack of sympathetic innervation will reduce sodium and water retention in the proximal tubules, and leading to increased susceptibility to hemodynamic insults. How we evaluate acute kidney injury in a transplant patient is very similar to a non-transplant patient, but we do have more factors to consider. We always look for calcineurin inhibitor toxicity, so we check tacrolimus or cyclosporin levels, because if those levels are elevated, reducing those can result in resolution of AKI. Rejection or recurrence of primary disease is very important. So if the primary disease is glomerulonephritis, we always keep in mind that that could be the cause of acute kidney injury. Rejection always on the differential, so we do check donor-specific antibodies, and we do kidney allograft biopsy if needed. And then anatomical causes, because these patients can have urinary obstruction from either autonomic issues from the bladder, or with the BK virus, they can have urinary stenosis as well. So we look for ultrasound with post-void residual. And then looking at the other viral infections, so BK and CMV virus, these can cause interstitial nephritis, glomerulopathy. So we normally monitor for BK viral load in the plasma and urine cultures if there is a concern for a UTI. So with the better immunosuppression, our kidney transplant recipients are living longer. But death with a functioning graft is still one of the most common causes of graft loss. And here you can see, cardiovascular disease is the major cause of mortality. Infection historically was the major cause, but now with better prophylaxis, things are better. And then malignancy is also one of the major causes. And these percentages have also changed over time. In certain countries, malignancy has surpassed infections. And we'll talk about each of these individually. Cardiovascular disease, as I said, major cause of death and graft loss. And this study looked at the mortality with cardiovascular disease in patients in general population, as well as in dialysis patients and transplant patients. And you can see here that there is a huge difference in cardiovascular mortality between general population and between hemodialysis patients. And although transplant does provide some advantage, but this mortality rate does not approach to that in general population. And also mortality in the spectrum of cardiovascular disease is also variable in kidney transplant recipients, but one distinct thing is that there is more arrhythmias, and that is one of the major causes of death among cardiovascular diseases. And it's also not surprising to see that the risk factors for cardiovascular disease are also a bit different as compared to general population. So we do have our traditional risk factors, but then we have immunosuppression, which is both diabetogenic and atherogenic. So their cardiovascular risk is high. I want to move on to post-transplant hypertension. So prevalence is almost 60 to 80%. As like other comorbidities, the pathophysiology includes not just the traditional risk factors, but there are non-traditional risk factors as well. So there are immunosuppression-related factors, which means calcineurin inhibitors and steroids. And then there are factors related to donor, for example, donor age and donor hypertension that contribute. And there could be transplant-related factors. There can be progressive allograft dysfunction. There can be transplant renal artery stenosis. In the management of hypertension in transplant patients, I just want to mention some unique transplant considerations that we don't have optimal blood pressure targets. There are no randomized control trials that look at these. We can use all classes of antihypertensives. We prefer to use calcium channel blockers because they can counteract cyclosporin and tacrolimus induced vasoconstriction. But we have to keep in mind of their interactions with calcineurin inhibitors. We do prefer to use ACEs and ARBs once the stable graft function is achieved so that we don't confuse the rise in creatinine with rejection. And then beta blockers are used as well because these patients have high cardiovascular risk. Then post-transplant diabetes mellitus, again, a very prevalent complication. And one of the things that contribute is immunosuppression because calcineurin inhibitors are directly toxic to the beta cells, and this, along with synergistic effect from steroids, results in new onset diabetes after transplant. And unfortunately, we don't have a lot of treatment options either. We can use oral hypoglycemics. We can also use insulin, SGLT2 inhibitors. These are safe and beneficial in kidney transplant patients, but we have to keep in mind these patients are at the risk of recurrent UTIs. So I wouldn't use it in patients who does have history of UTIs or who are prone to dehydration. We can consider switching immunosuppression as well, maybe choosing more steroid-free regimens, but again, keeping in mind the risk of rejection. I'm just going to briefly mention about post-transplant infections. So 70% of the patients will experience an infectious event within the first 3 years of transplantation, and sometimes the timeline of infection can give us an idea. The most common infection is urinary tract infection, and this is because of the lack of natural anti-reflux valve between the transplanted ureter and the bladder, and relatively shorter length of the ureter, which facilitates the ascending infection. We should always try to obtain filters prior to treatment. I'm just going to move quickly to the post-transplant malignancies, because kidney transplant recipients have at least twofold higher risk of developing and dying from cancer as compared to general population. And again, the risk factors are multiple, but immunosuppressants do play a role because we lose our surveillance and cancer cells can proliferate. There is also a role for oncological viral infections as well. Especially, I want to mention PTLD, which is associated with Epstein-Barr virus. PTLD is just a lymphoma after transplant. I'm just going to skip this slide for the sake of time, but this just shows the most common cancers after kidney transplant. And this is my last slide. So here are a few takeaway points. Kidney transplant improves mortality in patients with end-stage kidney disease. But I want to emphasize we have to choose our donors and recipients carefully. Kidney transplant is not the right treatment strategy for everyone. Cardiovascular, metabolic, infections, and oncological complications require careful monitoring and management. And most of the post-transplant complications are either related to immunosuppression or anatomical reasons. And then a multidisciplinary approach is essential to address the complexity of post-kidney transplant care. I just wanted to share this picture because we all may have seen this race in the Olympics. 4 runners take part, and successful teams require each runner to optimally perform their portion of the race in order to win. And we can relate this to the care of our kidney transplant patients. What I want to point out is that it's not just one transplant center's dedication to make a transplant successful. It is a multidisciplinary approach, so we do need help from our internists as well. Thank you.
Thank you so much, Dr. Kaq, for the vital roadmap on how we can better support our transplant patients in internal medicine setting.